Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Ara Metjian from the University of Colorado in Aurora, Colorado, Dr. Paul Coppo from the Sorbonne University in Paris, France, and Dr. Marshal Mazepa from the University of Minnesota in Minneapolis, Minnesota. They will be answering questions posed during a recent satellite symposium at the annual Hematology meeting on recent advances in the management of acquired thrombotic thrombocytopenic purpura. This episode is part of a larger educational program titled Acquired Thrombotic Thrombocytopenic Purpura, Clinical Application of Precision Medicine and New Guidelines. For more information on the experts, along with a link to the complete program, including downloadable slide sets, an expert commentary, and an on-demand webcast from the live event, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
All right, this is a question for Dr. Coppo. Can you re-explain the rationale for the CAPLAVIE study regimen chosen in your study? And also, is there data in pediatrics?
Okay, so the rationale is to address the three pillars of TTP, acquired TTP pathophysiology. So the rationale is to provide ADAMTS13 to these patients, to block the neoformation of microthrombi, and to block the formation of antibodies against ADAMTS13. So it is indeed a quite intensive regimen, but you have to keep in mind that in acquired TTP, all the game is made the 10 first days of the management, because simply most patients die within 10 days. So I fully agree with Marshal when he says that the best way to prevent unfavorable outcomes is to avoid them to occur. So for that, we used to treat those patients quite intensively from the beginning to prevent any unfavorable outcome. And regarding pediatrics, yes, there is some experience in the use of caplacizumab in pediatric cases. So in France, I'm aware about 8 cases. Most of them, I have to say, are young adults, just between 15 and 18. And if I remember, they were quite obese as well. So the use of caplacizumab was not so different than in adults. And the remaining ones, we have 2 or 3 cases of acquired TTP in infants. And we adapted the dose according to the weight. And I have to say that we could use it safely with no adverse events. And I'm aware about the UK group who has 6 cases of pediatric acquired TTP with more or less the same good experience.
All right, this is another question for the panel. What do you think about initiating rituximab the day after plasma exchange just finishes, rather than at the same time when the rituximab could be removed with plasma exchange?
I can start. I think certainly in the States, there is pressure to delay rituximab until the outpatient setting because of the way payment is arranged in the US. However, I think Dr. Coppo's data really nicely showed that earlier administration of rituximab, as was done in their trial, results in faster recovery of ADAMTS13 activity. And so there are cost issues on both ends. If we can have the patient get into remission faster, we can potentially use less expensive bypassing therapy with caplacizumab. So I favor earlier use of rituximab therapy rather than waiting. But certainly it's an option if you get pressure from your institution to delay therapy. I think the problem is a delay in immunosuppression just means a longer risk period where complications can occur. And I think early aggressive therapy it sounds like we're all in favor of.
Yes, indeed. Basically, patients need very small doses of rituximab to deplete enough B cells, immune cells, and block the formation of antibodies against the enzyme and improve the enzyme activity. Some works reported that 4 infusions of 100 milligram, despite daily plasma exchange, were basically enough So despite the fact that daily plasma exchange removes more than half of rituximab from blood, the remaining volume of rituximab is clearly enough to efficiently deplete B cells and induce biological effect. The second point is that rituximab anyway is not efficient immediately. So it is not so urgent as it is with caplacizumab to start rituximab so urgently frontline. One can tolerate, let's say, to start it some days after the beginning of the management. But caplacizumab, again, clearly is able to work in real time to block the formation of neothrombi and protect organs from injury.
Right. I think even with minimal loss of drug with the first dose, it's likely that with the second dose, there'll be no more plasma exchange. And clearly it has worked in the pre-caplacizumab refractory patients. So it's likely that that removal of antibody is not clinically important.
This is a question for the panel. Is there any research to make the interpretation of schistocytes more objective? In other words, is there automation or artificial intelligence culture counters?
I know there are artificial intelligence mechanisms. I think we have that at our hospital, but I think typically the presence of schistocytes is not a particularly debatable manifestation. I have seen certainly many cases of patients who are misdiagnosed as aTTP because they have very little anemia. So I think being attentive to the diagnosis, looking for some subtle neurologic deficits, potentially checking troponin in patients who you think may have TTP can be also more effective in making the diagnosis besides the concern over identifying schistocytes.
What is the mechanism of bleeding in caplacizumab AEs or adverse effects or adverse events?
Caplacizumab is an anti-adhesive agent that prevents the interaction between VWF and the GP1B receptor on platelets. So it provides a kind of von Willebrand disease of type 2M. So this is why it exposes patients to bleeding.
Yeah, and I think the data from I believe it was the Titan trial published, showed that essentially very quickly after caplacizumab was administered, there's no von Willebrand factor activity detectable. So, and I think that was initially when this drug was being developed, concerned about safety, but I think we've been remarkably pleased that the safety issues have been less of a concern. But it does very quickly cause acquired von Willebrand disease as presumably the mechanism for bleeding. But clearly we see bleeding in this disease occasionally too, essentially post-thrombotic bleeding.
All right. Is the practice of starting a newly diagnosed patient with TTP with aspirin sound?
No, on my side, aspirin addresses the mechanism of platelet anti-adhesion that is completely different from the mechanism involved in TTP, which is the VWF GP1B axis. So it's likely that aspirin has no role in the management of TTP at the acute phase. And a long time ago, some trials attempted to address whether aspirin had a role in the management of this disease. And as far as I remember, those patients experienced a lot of bleeding complications since they had a very low platelet count. So ISTH recommendation does not support the use of aspirin in these patients at the acute phase.
Well, and I think particularly if you add aspirin to caplacizumab, it's
asking for a
fantastic way to increase the bleeding risk. So I think if you had to choose between these two therapies, clearly the FDA-approved therapy with a specific target is a much better choice. So I would stay away from aspirin.
All right. The next question seems to be more of an aggregation of them, but apparently there is strong interest on this question. But what is the data for the use of caplacizumab in pediatrics?
Well, simply that even pediatric patients, reports show that these patients are similarly exposed to exacerbations, refractoriness, and death although the experience seems to report that death would be less frequent in this population than in adults, probably because, of course, those young patients are less comorbid. So that's it. Despite the fact that there is less death in this population, again, these patients are exposed to exacerbations, which means a prolonged treatment with daily plasma exchange and complications associated with this prolonged treatment.
All right. The next question for the panel. In a patient with SCA, which I'm going to assume is sickle cell anemia, with TTP, do you suggest caplacizumab?
Well, I think it depends how you define. I think we have to be careful about the definition because sickle cell patients can develop thrombotic microangiopathy that may or may not be associated with ATTP deficiency. So I think in patients with sickle cell anemia with thrombotic microangiopathy that fits the picture, clinical suspicion for acquired TTP, it would be reasonable to use caplacizumab just as we would in any other patient. But I think we have to be aware that that's a different patient population. Risk stratification strategies that were developed didn't necessarily include sickle cell patients. So simply being aware that there is a sickle cell thrombotic storm that can occur that may be not driven by ATTP, just the way transplant-associated TMA and other TMAs. I think we just have to be careful, but safety data are quite robust, and I think as long as we're testing for ATTP deficiency, it'd be reasonable.
All right. Is the panel seeing patients with immune TTP in remission with persistent low ATTP despite rituximab? And if so, what treatments might be pursued?
Yes, this is a scenario that occurs in 10 to 15% of patients treated with standard regimens of rituximab. So what to do in these patients to prevent clinical relapses remains an open question with quite a few studies. And our use is to intensify the treatment with rituximab in these patients and to offer them regimens that are inspired from those we propose to patients with low-grade malignancy B-cell lymphomas. So we treat these patients with rituximab for 1 to 2 years, one injection every 3 months. And we had some success. We reported that 70% of these formerly refractory patients with standard regimens of rituximab improved ATTP activity. Other scenarios can involve the cyclosporine A, for example, or some also suggested splenectomy.
Okay. Right, yeah. I think it's a pretty common referral to my clinic. And I typically recommend 1 of 3 treatments, splenectomy, pulse Cytoxan, or oral immunosuppression, such as azathioprine or mycophenolate, versus continuing it on rituximab. So, but usually by the time they come to see me, the referring physician and patient have given up on rituximab. So I would say the tendency is to move to other therapies. But the problem is we don't have any data to support what to do at this point. Right. So certainly a big need.
I'm going to combine these 2 questions, one of which is for Dr. Mazepa. What do you think about daratumumab for immune suppression in refractory TTP?
Sure. I think anti-plasma cell therapy is an exciting target, and there have been case series reported. I think the challenge particularly is getting this reimbursed in the US, since it's an off-label use. So it could be used in the hospital, but it's going to be challenging to get in the clinic. But certainly is rational, and there have been plenty of case series on the use of bortezomib. So would certainly make sense, particularly if anti-B cell therapy isn't working.
What are the triggers of TTP besides infection?
So the triggers of TTP are all those situations on which there is an stimulation of the endothelium that leads to the release of high molecular weight BWF multimers. So the most usual trigger is indeed infection, but any kind of activating agent towards the endothelium can lead to TTP, and this includes any surgical process simply inflammation and maybe some drugs that are able to activate the endothelium.
Yeah, I think the other is triggers we'll sometimes see as pregnancy. But I think any sort of immune stimulus can certainly bring on an episode.
All right. And in the interest of time, two questions. COVID-related question. What is the experience of the panel's patients with a history of TTP and COVID? Did they do worse? I'll jump in on that. I'll give my panelists a break, and I'll say, at least for my patients, knock on wood, I've not had any patients with TTP who have gotten COVID. I think many of our TTP patients are exquisitely sensitive to becoming sick, infected, and remaining out of the hospital.
Yeah, so personally, I had not so many cases of TTP cases with COVID, is the question. We anticipated at the beginning of the pandemic regimen of treatment in case of intensive care units could not manage such patients because of overwhelming cases of COVID with Spiro Cattelan and other colleagues. And the suggestion was to treat those patients indeed with only plasma infusion, caplacizumab, and immunosuppression. I'd have to say that on my side, we didn't need to apply such a regimen. And I'm only aware about maybe some very exceptional cases of TTP triggered by a COVID infection. And I'm even aware about some cases where COVID was diagnosed while the patient had no sign of COVID simply by a systematic search.
It seems to be the bigger concern among my patients has been the risk of relapse with the COVID vaccine, which in my small cohort we haven't seen, and even the ATTP has stayed stable. And then I've had a couple patients with newly diagnosed TTP who received rituximab just before the vaccines came out. And remarkably, those patients actually did quite well with vaccination in terms of producing anti-COVID antibodies. So I would say overall, thankfully, a positive experience.
Yes, in that way, we had some cases of TTP following COVID vaccine. And the experience is that vaccine may be usual trigger, but regarding some epidemiological data, the vaccine itself may not favor the formation of antibodies against the ATTP.
The aggregation of platelets induced by the ATTP deficiency, does it not induce activation of the coagulation cascade? The platelets are aggregated by long chains of VWF, but not activated? So,
yeah, I don't think we're seeing true activation of coagulation the way we would with DIC, say, or deep vein thrombosis.
Well, it's not to that extent, but we do see thromboembolic events with TTP. It's just not the main risk.
Yeah, absolutely. Yeah, and it's hard to know exactly. It still seems the pathophysiology is still largely platelet-rich thrombi rather than traditional fibrin-rich thrombi.
Right.
Yeah, there is indeed a risk of a thromboembolic event in patients with TTP, and reports mention that those patients may experience thromboembolic events in around 12% of cases. And an interesting aspect is that on the caplacizumab cohorts, the use of Capla apparently did not protect those patients from macro thromboembolic events. So formally, we were a bit scared about preventing macro thromboembolic events with the use of caplacizumab. But now that we observed such thromboembolic events, we are doing a step back and use again prophylaxis against thromboembolic events despite the use of caplacizumab.
Thank you very much, Dr. Metjian, Dr. Coppo, and Dr. Mazepa, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Acquired Thrombotic Thrombocytopenic Purpura, Clinical Application of Precision Medicine and New Guidelines, and to download the PDF associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.